CMDIR webinar, and we are going to be learning about muscle ultrasound and its use as a diagnostic tool in the congenital muscle disorders. We're pleased to have Naz Dastgir, who is a pediatric neurologist currently at the NIH, giving us this fantastic overview. And Dr. Dastgir is not only really moving forward the field in terms of increasing awareness for how ultrasound can be used to help achieve a diagnosis, but is also looking at ultrasound as an endpoint for gauging quantitatively how much a muscle may be involved, which of course can then be used as a biomarker of sorts for clinical trials. So without further ado, I turn it over to you, and thank you so much for joining us today.
Okay, thanks for having me. So this is just going to be a basic overview of what muscle ultrasound is. And obviously, feel free to interrupt me at any point if I'm going too quickly or if you have any questions before I move on to the next slide. So I have nothing to disclose. And the goals of this lecture are just to review the use of muscle ultrasound, discuss techniques, review pathological findings, and also potentially do a demonstration, which is difficult to do over the telephone, but I can kind of go through the process of how this works for you. So in terms of muscle imaging, there's a variety of techniques that are available, and this may or may not be used regularly in an outpatient clinic setting for a variety of reasons, but one of the most important reasons in the pediatric population is that kids can't generally lie still for imaging, and they often require sedation for it. So you have to have enough benefit out of the procedure to outweigh the risk of the procedure, and really identifying pathognomonic features or characteristic features of disease on muscle MRI haven't been clearly cataloged or actually shared among the community enough for people to say, oh yeah, it's worth putting my kid under sedation for a muscle MRI or even a muscle CT scan. So that's why muscle ultrasound is also really important, but I'll go through the different techniques that are available. So we have CT scans that are available, and over to the right, these are some images acquired from that. The pros of a CT scan is that it's a quick assessment. It's usually about 10 to 15 minutes of acquisition of time to actually get these pictures, and you can get a good assessment of the shape of the muscles and whether or not there are dystrophic changes in the muscles, and it allows for evaluation of deeper groups of muscles. So when you look at a CT scan or an MRI, looking at these images over here, this is a person lying down with their feet pointing towards you. So this side over here is the right side, this side over here is the left side, and actually this is a mid-thigh view. And up around here where you see this bright spot is the bone, it's the femur, and here is the tibia and the fibula down here below. And when you look at this image here of the CT scan, you can see that there are some boundaries of muscle marked here by what you call fascia layers. The fascia layers are essentially similar to what you see in chicken when you're trying to cut it, and there's like a layer that's a very kind of clearish white membrane. It's a similar type of thing, and it kind of segregates the muscles into different groups so they can perform different functions in different directions. So as you can see, you can kind of see a distinguishing fascial boundaries throughout the muscle here, but it's not super duper clear. But what you do see is that here you have bone, here you have muscle, and here you have, above that, sorry, here is what we call subcutaneous fat, and then above that is skin. And if you look, it's really interesting because you're looking at this patient, who's actually an adult patient, and you're seeing that this subcutaneous fat is of the same intensity as the muscle, which means that this muscle is actually all made of fat. So this muscle is no longer really mostly muscle, it's mostly fat, and this patient was severely compromised. We ended up getting a CT scan on her recently because she actually couldn't lie flat for the MRI too long because of her respiratory issues, and she hadn't yet been intubated. So this was the quickest study that we can get. Now the cons to CT scan is that you get limited soft tissue contrast, and it impairs the sensitivity to detection and changes in the muscle. And kids still won't sit still for a CT scan. So even though this woman was able to do it for a short period of time for us, generally having a kid sit still for just a snapshot of a picture is hard, let alone having them sit there for about 15 to 20 minutes without moving. And the other con is the obvious radiation that comes along with the CT scan. So then we move on to MRI. So you can see here that you can really see a nice differentiation between the muscle tissues in the MRI. So it gives you high soft tissue contrast, allowing for excellent assessment of the muscle. You can pick up on dystrophic changes and inflammatory changes. It has higher sensitivity of detection of dystrophic changes as compared to CT scan. There is no radiation, and it can be performed in and rated in a standardized manner with good inter-rater and intra-rater agreement. The cons is that this study often takes at least 40 minutes to an hour at times. So the likelihood of having a kid that's very good even sitting still for that period of time is really hard, although we do make efforts to play movies for them, have them listen to music, but it's still really difficult. So obviously in younger kids, I would say under the age of 4, these children would often require sedation in order to get these images. And over the age of 4, you often have something called motion artifact, where it's really hard to get a good image. Now for MRI, they also have rating scales that have been developed where they grade them as 0, 1, 2A, 2B, 3, or 4. And they're described as normal appearance, early moth-eaten appearance with scattered small areas of increased signal, late moth-eaten. So these are kind of standardized things that have actually been recently reviewed and encouraged in a consensus statement out by the Treat NMD group in 2012. So then we move on to muscle ultrasound. So the pros of muscle ultrasound is that it's a rapid procedure that you can do at the bedside. It basically just takes about 15 to 20 minutes of time. You have no issues with claustrophobia because if you do actually go into an MRI, if you've ever been in one, it involves you going into a tube. That's a pretty tight space, which can be uncomfortable at times and also can elicit some claustrophobic anxiety. It's a good measure, procedure to measure muscle thickness and also muscle echo intensity, and I'll talk about that more shortly. It's non-invasive, doesn't require sedation, there is no radiation, and it's relatively low cost. Now the machine that we use here at the NIH is pretty pricey, but our travel machine is actually much more affordable, and definitely both are much, much cheaper than MRIs. The cons is that the image resolution may be less than an MRI. There's also technician and physician technique variation and image quality, and I'll talk more about that shortly. The application also tends to be limited to superficial muscle groups, meaning the ones that are closer to the surface or closer to the skin, because sound wave reflection and absorption leads to difficulties in displaying the deeper structures, and I'll talk to you more about that shortly. And also with the ultrasound, so far what's been described is a low inter-observer agreement and intra-observer agreement depending on level of experience. So it makes this a strictly standardized exam really crucial when you're actually trying to use this as a biomarker. So just talking more about muscle ultrasound, it's a well-established and validated diagnostic imaging method that was first reported in 1980 as a method for evaluation of patients with suspected muscle disease. It may be used for diagnosis and monitoring of disease progression, and it has the unique ability to perform dynamic imaging. Dynamic imaging means that you can actually watch how the muscles move, or you can actually see movements that are not created by the patient themselves, but they're movements of the muscle that are often associated with inflammation or degeneration of the muscle tissue as it relates to motor neurons. So this is something that's very unique to ultrasound that you'll never get in MRI or CAT scan. So the basic MRI ultrasound review here is that when you have the sound sent off by the crystals in the ultrasound probe, they basically reflect off of the different surfaces in the muscle. And there's a standard image that comes across that's pretty dark. It doesn't have a lot of reflection or increased echo intensity or whiteness to it. But what happens is when you have muscle that's pathological. You have increased fat deposition within the muscle, or you might have more increased fibrous tissue or scarring tissue. And those create boundaries to the sound going through. So whenever the sound hits that area that's a little pathological, say for example with these little bubbles here in this picture, it's going to bounce off the sound and it's not going to let a lot of the sound pass through. Now, just a little bit of the sound bouncing off is going to give you this mild haze to the ultrasound picture. If it's a denser scar tissue or denser fat deposition, it's going to be much brighter. And sometimes it's often too bright to pass through that layer that's of scar tissue and fibrous and fat tissue that you can't actually see what's beneath it. So that's one of the limitations of the procedure. So, as I said earlier, the amount of returning echoes per square area determines the gray value of the image, aka the echo intensity. So a child with a myopathic disorder would have increased echogenicity or echo intensity. The largest differences in the acoustic impedance are found between bone and air, and this transition results in a strong reflection or bright spot on the ultrasound image. So the ideal image that you can get from an ultrasound is that you're actually going to be able to visualize the bright spot from the bone, so you can see all of the muscles coming from just beneath the skin. You can see the subcutaneous fat, the muscle, all the way straight down to the bone. And to be able to see that bright spot is actually something that differentiates a patient with a moderate myopathic disorder to a severe myopathic disorder. Because once it becomes severe, you have so much reflection of those sound waves that you cannot pass through deep enough to actually visualize that bright spot. The importance of that bright spot is also related to your probe. It also signifies that you're in the right position or you're directly perpendicular to the bone. So it's always really important to try to visualize that if you can. So that's kind of what I was just talking about. So normal muscle is of low echo intensity. It's black in appearance. It's divided by echogenic sheets of perimesial connective tissue. Perimesial means it surrounds the muscle fibers. And it gives you this speckled appearance in the transverse plane, which is usually where I take pictures, which is basically just slicing down the leg as if you were just slicing across it, not down the long axis, but the short axis of the leg. And you basically get used to the distribution of the normal little speckling of fascia. Sometimes some muscles have a central fascia within the muscle tissue itself, and I'll show you why that happens. But it's all related to compartmentalizing the muscle for function. So once you get used to how the muscles tend to be arranged and what the regular organization of the muscle tissue is, you have an idea of what the normal echogenicity of the muscle is. And each muscle is a little different. And then based on that, getting your eyes used to that, you can start to tell when things start to kind of deviate from that or change. So normal muscles, as I said, have this variability, which can be due to the fascial planes, but it can also be due to the different orientation of the muscle fibers, depending on where you're hitting them and how they're oriented. So this is a nice picture of how muscle actually gets arranged within the body, and it's actually really, really interesting. It's all about body mechanics and physics, essentially, what works best for the different locations in the body. For example, if you ever see people with their abdomens having six-packs, this is essentially what they have. It's called strap muscle with tendinous insertions here. So this also has to do with the mechanics of how you're basically going up from a supine to a seated position and to keep people straight, and this allows for the appropriate tension distribution within the muscle. If you look at the biceps here, this is what you call a fusiform muscle. So there's just basically one big bulk of muscle, one long tendon, and one shorter tendon up here at the top. And that again has to do with tension mechanics. This is an adductor muscle that brings your legs together. This is a bipennate muscle where it has two it's divided in the center to create two sections. These areas are basically areas of pennation. And this, as you can tell, is at an angle, and this also has to do with force and tension on the muscle fibers itself. It's all really beautifully planned out the way it's organized. So, so it's really important to get to know, because these orientations all kind of change what the muscle looks like on the ultrasound. And here you can see in a bipennate muscle, you'll see a nice little fascial plane right here in the center, and then some fascia here on the sides. This gets to be really important in diseases that affect the extracellular matrix in muscle, and I'll show you some pictures. But this ends up being called the central fascia of the rectus femoris muscle. And then here in the deltoid, you can see it's multipennate. So it doesn't have just the one fascial layer in the center. It has 1, 2, 3, 4, 5 going through. So it almost has like a flower petal-like appearance when you look at it when you're making a slice through it. So that's just important to keep in mind when I start showing you these photos. Now, muscle echo intensity doesn't just change because of all of these natural fascial boundaries. It also has to do with age-related changes. So it might be less, you might have less echogenicity as a child, but as you get older, there's more muscle replacement by fat, and you get more fibrous tissue, probably just from wear and tear. And that ends up becoming something called sarcopenia. And so there is increased echogenicity that normally happens in humans as they age. And here you can see that the muscle echo intensity in general tends to increase more so in women than in men over time. And there are grading scales for echogenicity. One is known as the HECMAT score. So grade 1 is normal. Grade 2 is increased muscle echo intensity with distinct bone echo, which is the bony bright spot that I was talking about. Grade 3 is marked increased muscle echo intensity with a reduced bone echo, so it's not as bright as it could be, but it's still there. And grade 4 is very strong muscle echo and complete loss of the bone echo, meaning that the muscle tissue is so much replaced by fat or fibrous tissue that the sound can't travel down to it to even give you a bone echo. Now there's efforts that have been made to quantify muscle echogenicity. So here, this is the thigh, like we were showing in the other pictures of the MRI and the CT scan. And this is a slice through it in the axial position, meaning not going down the long axis, but the short axis of the leg. And here you have the rectus femoris muscle, which is that bipennate muscle that we were talking about. Bipennate means it has that one central fascia layer, and this is the central fascia as you see it on this axial cut. Underneath it is the vastus intermedius muscle. Underneath it is the femur, and this is the bony bright spot. And so what people tend to do is they actually tend to circle these areas and then transfer them into a grayscale analysis for quantification of this grayscale. So I can look at this and tell you definitely this has what I would call mild increased echogenicity, right? We still have a pretty good bony bright spot. I can see straight through. But if you really want to quantify it and not make it more of a qualitative scale like mild, medium, moderate, severe, you can circle it and then put it through a grayscale, and here you can see that there's a tendency for more of these fibers to have more echogenicity than in a patient unaffected by muscle disease. Now there are things that could falsely make it look like you have more echogenicity in your muscle. These are related to the settings on the muscle ultrasound machine, such as increased gain can give your muscles a wider appearance. That could be mistaken for pathologically increased echogenicity, and positioning of the probe. So having your probe tilt one way or the other can actually change it. So you have to make sure that your probe is perpendicular to the muscle. Muscle thickness is another thing that we can measure on muscle ultrasound. So it's a reliable method to do so. You can get a cross-sectional area, and some studies have used this to establish muscle thickness in healthy patients. This is dependent upon placement of the probe. So as you can, if you recall from the picture of the muscles, the bulk of the muscle can differ in different areas. So you have to make sure that you're measuring the muscle at the correct area and you're getting the right cross-section to actually measure. It could also change based on the position of the subject. If the subject is pulling on this muscle, it's definitely going to get to have a smaller cross-sectional area as opposed to the muscle at rest. The age of the patient can affect the size of the muscle because it changes over time. The weight of the patient can affect the size of the muscle, and also sex. but primarily after puberty. So just to review, muscle ultrasound, with a muscle ultrasound, the examiner can assess atrophy of muscle, which is variations in echogenicity suggestive of fibro-fatty changes, and you can identify a pattern of muscle involvement, meaning, is the distribution of this increased echo intensity homogeneous or inhomogeneous, meaning is the whole muscle affected or just little splotches of the muscle affected. And also you need to look at which muscles are selectively involved, because this can sometimes help guide you to a diagnosis. You can use a muscle ultrasound to identify the right muscle to biopsy. A lot of times certain muscles are spared in certain muscle conditions. Say, for example, central cord disease. Oftentimes the rectus femoris muscle is spared, and oftentimes the rectus femoris muscle is biopsied. So if you use a muscle ultrasound to identify a muscle that looks myopathic, you could make sure to avoid the one that looks healthy and go for the one that looks myopathic. This is something that is also typically done with EMG. The downside to doing this with an EMG needle to pick up on myopathic changes in an electrophysiological way is that you actually damage the tissue when you're doing the EMG, and it leads to these inflammatory changes within the muscle. So typically when you do the EMG, you can't biopsy that particular muscle. You have to do the same muscle on the other side. And there are many times where people make mistakes with regard to that. And the other thing is that you can visualize pathologic dynamic changes in muscle. So just like I was talking about with the different changes, there is a certain type of movement in muscle that is very specific to motor neuron diseases such as SMA, and it's called fasciculations, and you can see this in the muscle. There are things known as myokymia. Myokymia can be related to some channel diseases. It could be related to radiation damage. And so that's something that can also be picked up on. And fibrillations can be associated with neurogenic disorders or related to the nerve, or it can be related to inflammatory myopathies, things that have a lot of active inflammation and muscle degeneration. So you can actually see all of these. Now you can also pick these up on EMG when you stick the needle in the muscle. These also have characterized kind of action potential appearances on a screen, but you can imagine that oftentimes these changes are also patchy, and you might stick your needle in one area that's not affected. And additionally, with the ultrasound, you can actually see the breadth of how far these changes exist, meaning how many different muscles is it actually affecting and actually visualizing it. So that's an added benefit to the muscle ultrasound. So what I'm going to do here is kind of show you some pictures of normal muscle just to orient you here. So this is an ultrasound picture. This is an MRI picture. And right here we have a picture of a bicep muscle. And underneath it is the coracobrachialis humerus bone. You see this bony bright spot right here. Same changes here. Here is a tricep. This is again MRI image. This is ultrasound image. This is the lateral head of the tricep, which is where I usually take my photos. This is the anterior head, or the medial head, sorry. This is the humerus again. So typically you just get a big shadow underneath the bony bright spot because the sound can't penetrate through the bone. Subcutaneous fat, and above that is skin. Here's the rectus femoris muscle. Rectus. Central fascia. These are normal fascia planes within the muscle. Again, it's just a matter of getting your eyes used to it. Even the subcutaneous fat, these aren't fascial planes, but they're kind of organized in a certain way. So you see these extra lines coming up here. This is all normal, and here you might say that this is a little bit of increased echogenicity, but it's actually not. It's an artifact. If you look at it going across, it actually spreads all the way across here, but it's kind of hard to pick up on this picture. But otherwise it looks normal and healthy. Vastus lateralis muscle. So here's the vastus lateralis. And underneath it is the vastus intermedius. And again, the bone is the femur. Right next to it over here would be the rectus. These are adductor muscles. So this is sartorius muscle. This is a gracilis muscle. This is an adductor longus, adductor magnus. These are your hamstrings, 1, 2, and 3. This is semimembranosus, semitendinosus, biceps femoris. These are your gastrocnemius muscles, or your calves, and your soleus. This is your tibialis anterior muscle, your extensor digitorum longus, and your peroneus. So just to get, and this is actually your tibialis posterior. This is the tibia bone and the fibula. And just get your eyes used to the fact that this muscle should be pretty dark when you look at it. And these are the paraspinals. This increased echogenicity here is pretty normal. And this is the ligament just above, between the vertebrae that you see sometimes when you're taking these pictures. So let's talk about what happens when you have, oh, do I have any questions at all? Is everybody okay with the pace here, and anything you want to stop me on before we go on to the different changes in the muscle that you see with the variety of disorders?
So far, so good.
Okay. So basically, you have a variety. Do you guys hear that clicking sound by any chance? Or no? Is that just me?
I think it's just you.
Okay, sounds good. I can deal with it.
I can hear it on my end.
Oh, you can?
Mm-hmm.
Okay. Yeah, I'm not sure what it's related to, but I'll try to keep talking here.
Yeah, I'm hearing it too. It just started a minute ago.
Mm-hmm. Well, I'll try to talk through it here. Oh, okay, now it kind of stopped. Okay. I'm sorry? Can you hear me?
Go ahead.
Okay, someone said I'm muted. I'm not sure who that was. Okay, I will continue. So in terms of neuromuscular disorders, there are neurogenic disorders that you can pick up on. The ultrasound findings of neurogenic disorders are a little bit harder to distinguish than the myopathic changes, but if you get your eyes used to it, you might get a bit of a hint about it. So basically the difference is with a myopathic disorder, where it's directly just related to muscle changes or muscle disease, you get a diffuse homogeneous change within the muscle when it comes to increased echo intensity. In a neurogenic disorder, because you have select groups of muscle motor neurons dying, basically you have patches of healthier looking muscle interspersed with patches of not so healthy looking muscle, or muscle with increased echogenicity. So the key to identifying neurogenic disorders is seeing that they're inhomogeneous involvement of these increased echogenicity, areas of increased echogenicity. They're patchy, they might be stripy, and they're interposed with hypodense areas. Now, oftentimes the areas that are more affected also look a little atrophic, and the areas that are healthier look a little bit hypertrophic, and that actually correlates with the mechanism of disease, where you have a bunch of motor neurons that are left over and are healthy, taking over the job of the motor neurons that have died and kind of making the most out of that muscle tissue that's left behind. In young children, there also might be another thing that you can see with motor neuron disease is an increase in subcutaneous tissue diameter. And you might actually see fasciculations as well. So this is the rectus femoris muscle in a child with SMA type 2, which is a motor neuron disease. So here you can see that there's a lot of increased echogenicity. You do see your bony bright spots, so I would call this more moderate increased echogenicity. But within here are these darker areas. So if this were a myopathic disorder, I would expect the whole thing to be grayed out or whited out. But there are these areas that are patches of healthier tissue, and they drew it out over here. And these are the hypertrophic and spared fibers. And these denser areas of more increased echogenicity are the atrophic and more affected fibers. So these are things to look for when it comes to neurogenic changes. And this is one of our patients with SMA type 3, And it's the same type of phenomenon where you see these patches, this is her deltoid, patches of healthier tissue interspersed with more atrophic tissue that has more echogenicity when you look at it. You can also see this manifesting as streaks, and I think that has to do with the orientation of the muscle fibers when you look at it. So this is streakiness that's also consistent with a neurogenic disorder. Same type of streakiness and interposed hypoechoic tissue. And it's the same type of thing that you see in the muscle. The muscle is not all diffusely involved. It's just these patchy areas that are being shut down as the motor neurons die. These are just more pictures of her thigh or her quads, and it shows that she has this streak-like quality to her muscle tissue that's unique to the neurogenic disorders. And believe me, I think that this is really hard to get your eyes used to seeing if you're not used to seeing the regular distribution of fascial planes within the muscle. Now for muscle ultrasound in myopathic or dystrophic disorders, as I mentioned earlier, you can see homogeneity of increased muscle echo intensity. And there are some exceptions to it being homogeneous, particularly when it comes to disorders like collagen 6 myopathy, where a lot of these the changes in the muscles tend to start from the areas of the fascia or the connective tissue inward. And when it starts around the fascia, we remember, for example, in the rectus femoris muscle, it's a bipinnate muscle with a central fascia. So if the changes in the muscle are kind of starting from there, you can imagine that you're going to see a more localized increased echogenicity right around that central fascia. And when that happens, it gives the appearance of what we call a central cloud. And I'll show you a picture of that as well. And then you also get this phenomenon called rimming with collagen 6 disorders, where the changes are also coming from the outside fascial layers inward. And when the fascia is more affected, again, it's all around the borders of the muscle, and it gives this rimming effect. I'll show you a picture of that as well. The muscle in these disorders may be hypertrophic, atrophic, or normal, and there might be sparing and or selective involvement of some muscles. This is kind of a thought algorithm about how to approach the diagnostic workup of muscle disorders based on what you see on either muscle MRI or muscle ultrasound, which we don't have to go through right now. And I'm going to give you some examples of myopathic disorders that have some characteristic muscle findings on ultrasound. So SEPN1, also known as rigid spine myopathy, it causes selective affliction of the sartorius and posterior compartment muscles and have a relative sparing of the quadriceps and gracilis muscle. So this is the adductor area. This is the sartorius muscle, which is typically a little bit more echo-intense than the gracilis muscle. But here it's more so than your baseline. So that's abnormal. Here you have an adductor longus that looks relatively spared, but then look at the adductor magnus, which is much more involved. And this actually correlates with images that have been drawn or schematics that have been drawn in that recent TREAT NMD paper about the patterns of muscle involvement with the different disorders. So here you can see that just with the muscle ultrasound, you can identify that this white sartorius, meaning it's the most affected, is right here. Gracilis, dark, less affected, actually least affected, right here. Adductor longus, least affected, right here. Black is least affected. And adductor magnus is more affected. So pretty consistent. So if I had a clinical exam, I usually, based on a clinical exam, will come up with a differential diagnosis, but then if I saw this on the ultrasound, I think it would be really easy to try to hone in on what might be going on with the patient. For Duchenne, so take a look at Duchenne. Duchenne is diffuse myopathic changes. Pretty much the whole thing is affected throughout. Here you can see that this vastus lateralis, which is just lateral to the rectus femoris, is so dense that I cannot even see past it. I don't see any bony bright spot. I don't see any bony bright spot below this rectus femoris either. So it's dense myopathic changes in Duchenne. When we're looking at different limb girdle muscular dystrophies, I won't go through the details of this, but I'm just trying to prove to you that this does match what's been described. So the tibialis anterior in this patient with LGMD2I is a little bit bigger, and it's spared compared to everything else. And then when you look at their hamstrings, look at this photo here. We have the biceps femoris muscle here, semimembranosus, semitendinosus in the middle. Darker is less affected, so semitendinosus is spared. Semimembranosus more affected, biceps femoris more affected. For RYR1, or central core disease, if you look at this photo again down here, you see sparing of the rectus femoris muscle. We have the same thing here. We've also noted in some of our patients that there's relative enlargement of the rectus femoris muscle as compared to the other surrounding muscles. That's not been described in this paper, but it is the case in a lot of the ones that we've seen. Here you have the vastus intermedius that's more involved. Oh yeah, it is more involved. Look at that. And not too involved that I can't see down to the bony bright spot. Let's take a look at the sartorius and the gracilis. Oh, okay, so the sartorius is again involved. The gracilis is less involved. The adductor longus is less involved. The adductor magnus is involved. So putting all of this together, and you have a history of a patient that's consistent with RYR1, this really helps you hone in on the diagnosis. And then we have collagen 6 disorders. So I was talking about the bipennate muscle of the rectus femoris muscle, where the myopathic changes extend from the central fascia going outward. So we see that right here, and this is the central cloud on the MRI. I hope you can see that here as well on the ultrasound. And then we also have changes extending from the fascia inward, extending from the fascia all throughout the vastus lateralis intermedius inward. Here we have it again, increased myopathic changes extending from the outside of the rectus muscle inward, more sparing within. The same type of rimming. Again, sometimes it's a matter of getting your eyes used to actually seeing this, but I can see a rimming here around this tibialis anterior muscle. I can see a rimming around this medial gastroc muscle. So there are pitfalls to ultrasound. Pressure on the underlying tissue provided by the examiner, if your hand gets tired from holding it for a long period of time, can cause false visualization of increased echogenicity. Changing in position of the limbs being examined may alter the direction of muscle fibers and result in falsely increased muscle echo intensity. Contraction of the muscle by the subject may cause falsely increased echo intensity, and angle of the probe might lead to changes in echo intensity. So in order to help out with that, you should use a generous amount of contact gel to ensure optimal acoustic coupling and prevent pressure on underlying tissue. And to compare muscle thickness or muscle echo intensity between subjects and over time, you have to make sure that you have your patients being measured in standardized locations. And this is essentially what we're trying to do at the NIH right now. We have essentially 85 patients total, I think in the end, once I get all of my unaffected girls in, that we're going to be able to draw from with regards to muscle size, according to a variety of different age groups. So we're going to be able to talk about muscle thickness in certain muscles, muscle area. And we're also going to talk about grayscale and muscle echo intensity that falls in the range of normal for kids that are unaffected by muscle disease, and compare that echo intensity in children with the variety of muscle diseases. And another pro is to make sure that your bright spot is brightest, so that you know you're directly perpendicular to the muscle when you're examining it. So another thing that we've tried to do at the NIH is try to make this as easy of a recipe as possible. And so I actually worked with some of the engineers here to try to come up with this very, very complex way of making sure that my probe is perpendicular to the muscle, and I'm not putting too much pressure on it. I wanted to put a pressure sensor on it. And one of the engineers says, well, why don't we just use a thermoplast that they use for casting, put it around the probe, and make wings for it so it could just stay there on its own and be perpendicular. And I said, my gosh, that's brilliant. So that's actually what we've done. So we just thermoplasted, we made thermoplast molds of my probes, and now we're able to keep the probes in a steady perpendicular position. with a steady pressure. And that's about it. So thank you so much to Anna as usual. Karsten is my attending here at the NIH, and Catherine Alter is a physiatrist here at the NIH that's helped me a lot with learning ultrasound and has hooked me up with the engineering staff here at the NIH. Any questions?
So what do you think the likelihood is that people will be going, as more and more people get more confident with muscle ultrasound in terms of diagnostics, from muscle ultrasound to genetic testing and skipping muscle biopsy?
I think that it's very likely that muscle biopsy is going to be phased out for sure. That's my thought, because it's an invasive procedure. I understand that biopsy can be used to guide a lot of diagnoses, but I think that once we have a lot of these pathognomonic changes in muscle identified, I think it'll really be helpful in guiding the genetic testing. The limitations to this is that if you get someone really late in the course of disease and not so early in the course of disease, for example, like our collagen 6 patients that have been kind of getting worse over time and have had this disease for a long period of time now, you don't necessarily see the central cloud as clearly in them as you would in kids that are younger. So that's one thing. So because in the end, everything starts to look the same. So I told you that the rimming of the muscle or the central cloud starts from the fascia, but once it progresses beyond that point, then the whole muscle is involved. So it's really hard to kind of distinguish at that point. But then again, at that same time, if you were to biopsy that muscle, all you would be biopsying is fat, pretty much. So yeah, I think that the tendency is going to be moving away from muscle biopsy. So I also think that the genetic testing is going to surpass everything else. I think that genetic testing is going to get a lot cheaper and a lot quicker. And it's going to be something that people are just going to run people on massive chips that are geared towards muscle disease and then pick up the diagnosis right there. I think that the ultrasound and the MRI is going to be really helpful as an outcome measure to see how people are responding to therapy.
Do you want to, go ahead.
I'm just wondering, do you think that the ultrasound would be useful in helping to diagnose a patient with Nemelin myopathy?
Yeah, so there are some findings that have been described in Nemelin myopathy, but not that clearly as other disorders. But I bet you if I were to be able to get a cohort of Nemelin patients and do ultrasounds on them, I'm sure I could find features that are characteristic for that disorder.
How would you like to travel to the Nemelin myopathy family conference this summer?
I would love to. I love the Nemelin patients.
Stacey,
Yeah.
I think you have work to do.
Yeah, we're having a family conference in Canada this year in July.
Oh, really?
Yep.
Is it patients come there and are they actually examined there, or is it just a conference?
Well, we're setting this up actually as more of a family forum. So unlike some of the past conferences where we did kind of have a scientific focus, this one the organizers are trying to keep more as a family focus. So there might not be a lot of opportunities for a lot of science to be put in above and beyond what we've already put into it. Mm-hmm. But the idea of the conference is to bring together families from all across the globe to one place so that families can meet one another, get that support that they need, and get some education through the different presentations and talks that are going to be scheduled while we're there.
Mm-hmm. Yeah, that would be awesome. I mean, I would also love to see if they could be funneled to come down here to the NIH. And then basically we can characterize what their muscle looks like under our natural history protocol. We can do ultrasounds on everyone, for sure. And that would be really great to have if you have a nice cohort to work with.
Would there be any cost to the patients for doing that?
I think that it should be covered. You mean in terms of travel costs and things like that?
Yeah, just any costs at all to them to contribute in this way.
I will talk to, I'll be in touch with you about it to see. I think that we should be able to cover travel costs, and then the ultrasound obviously is just me, and then I'm sure we can even, if they're willing and able, we can also do a comparison on the MRI. I honestly, I have to give you a disclaimer. I do think that MRI is the gold standard because you can see the quality of the MRI images compared to the ultrasound. The area, where ultrasound excels is just in the area of comfort to the patient, meaning it's a quicker procedure and you don't have to sedate kids for it, and also you can get that dynamic imaging. But I think ideally, like in an MLN population, I would love to have them all go through MRI, have them all go through ultrasound. I also am doing a lot of studies on a new software on the ultrasound that measures muscle stiffness. I would love to do that on them and then basically characterize their condition on an imaging perspective.
Okay. I think if nothing else, if we can at least expose this option to the families, and let them know that there is an opportunity to visit your lab and have their muscles characterized in this way. You know, maybe we can get things moving in that direction to help produce a database of information for you.
And I'm scoring, I'm working with a muscle radiologist right now, and we're scoring all of our muscle according to those standardized scales. And he primarily works with myositis, but hasn't worked much, and as nobody really has, hasn't really worked much with myopathies. And if you look at a lot of the studies, a lot of the people who read muscle MRI for myopathy purposes, a lot of them are radiologists. I mean, a lot of them are neurologists, and I thought it would be really nice to get a radiologist perspective and expertise and kind of put that together with my own exposure and Carson's exposure to put together like a really good review of all of the muscle that we have so far. So having Nemelin as part of that would be fantastic.
Oh, sure. Yeah. Is there any way that you could travel to Canada if there was an opportunity for you to maybe give a short talk?
Yeah, sure. If it would be of help, yeah, for sure. I can talk to the big boss.
Okay. Okay. Well, we can look into this kind of on the side.
The only thing is that if it's not interfering with our summer study here in July, that would be my only thing. I don't know. And
no, it isn't. It's not that weekend. What weekend is it again? It's the last weekend in July, correct, Stacy?
Yeah, I think it's the 26th. Let me check my calendar here.
Naz, it would also be a great opportunity to meet up with some of the Canadian neurologists before we do our TLC clinic, because they are all aware of the Nemelin myopathy family conference that will be taking place.
Oh, awesome. Yeah, for sure. I mean, that would be great.
Yep, it's July 26th through the 28th.
Oh, yeah, that's perfect.
Yeah. I think that would be a lot of fun. It would be great if a room could be set up where Naz could already gain maybe a couple of images just to introduce the concept and also get a sense of how the muscles are behaving. And then, Naz, I think a really great idea would be to write this up again as a short study protocol under clinicaltrials.gov, because this would be very helpful then for families to be able to find it within the natural history protocol that already exists at the NIH that is specifically then looking at Nemelin myopathy.
Okay. For sure.
Yeah. And I'm sure Stacy wouldn't mind helping you put that together for clinicaltrials.gov.
Stacy just got signed up. I'm just kidding.
Everybody knows. Start running.
I think it's great. I mean, I think that the major benefit of the NIH right now is that these MRIs are covered through the clinical center. If you try to do this study anywhere else, it costs thousands upon thousands of dollars to do. So I figure any chance we have to use this resource here is worth it. So I'm really happy to make sure that these MRIs get done, you know, because I feel like we have this beautiful resource here. We have nice protocols set up to run and get these images, and it would be really great to characterize these patients.
And Stacey, Naz is there for just one more year. Maybe what we'll do is we'll set up a follow-up phone call, and I'll walk you guys through clinicaltrials.gov. And Sabine can be on the phone too because she's become the expert. Then we can just go ahead and set that up.
Yeah, that would be great.
Okay. Really. I wanted to know, Naz, if you could give just a couple of words about outcome measures to explain again to the whole group what is an outcome measure and how you see imaging as working as an outcome measure. And I'd love to get your thoughts on that as well.
Okay, so my definition of outcome measure is essentially something that you could follow over time in patients. It may or may not be unique to a patient population, but it could be unique to that one patient as well. But typically it is unique to a particular population of patients. But I think it's really important to invest in identifying proper outcome measures that are painless and easy for kids to go through, because it's something that we definitely need for the upcoming trials that will be coming up in this field, particularly with the advent of like the you know, the rise of gene therapy, which I think is going to explode in the next few years. Right now I'm part of some other trials for Duchenne, for example, and they do repeat muscle biopsies on these kids, and it's really hard, although they go through it, but they get repeat muscle biopsies, maybe 3 or 4 during the entire trial. And obviously parents are desperate and they're going through it, but it would be really nice to have other outcome measures to use that are painless and can be followed closely. So that's why I've put a lot of interest into this new type of software that I have. So before I talk about this software, what we do have is muscle thickness that we can measure and compare to kids that are unaffected with disease. And there's also grayscale analysis. Grayscale analysis is one of the most tedious things I've ever done, and I can tell you that it's probably something that nobody ever wants to do as part of an outcome measure for a study. So I will definitely do it and describe it, but I think it's just something that's not sustainable. Muscle size is easier to measure, and you could do it directly on the machine. But this other software is essentially, it's something called acoustic radiation force imaging. It sounds really dramatic, but it's not. It's essentially, you send one pulse through the ultrasound, and it basically measures the rebound of the muscle, or the sound that reflects off of the muscle, in what's called a shear wave velocity. So this velocity gets measured, and it's actually recorded in meters per second. And in theory, if the muscle is stiffer, the muscle bounces off a lot quicker. If the muscle is softer or fattier, it bounces off a lot slower. So I've spent a lot of time trying to get patients that are unaffected by muscle disease to find values for like a quote-unquote normal range. And then I have been getting data on our collagen 6 patients and Lama 2 patients based on the ultrasound study that I did for the summer study that happened last year. And I've also been able to do this in Duchenne patients. And so far, preliminarily, it looks like the tibialis anterior muscle is the most consistently distinguishable muscle in terms of muscle stiffness between all of these disorders, meaning that the tibialis anterior muscle velocity in kids with Col6 or Lama 2 is very, very fatty and slower in speed in terms of the rebound of the sound off of it, as compared to kids, where it's really fast, meaning that muscle is either super edematous and really stiff because of that, or it's stiff because of fibrosis. It's very distinguishing, very, very interesting. I haven't yet done the data to see how it changes over time. As part of the Duchenne study that I'm working on, we're getting measurements of the muscle every 3 months, And some of these kids are on placebo, and some of these kids are receiving therapy. And so I'm going to have to see how that changes in my results. And I'm blinded to this as well. But I'm going to try to see if my results, if they improve or they stay the same or worsen, compare with who's actually getting therapy versus not, and how outcome measures are changing as well. So that's essentially, I think, what's going to be the future of imaging as an outcome measure. For muscle MRI, there's some work that's being done that I'm helping with in another protocol where for an adult disease, primarily adult onset disease called hereditary inclusion body myopathy, and they're using MR spectroscopy to measure changes in the muscle over time and whether or not these changes are reversible with this medication that they're administering here. There is also the possibility of using a similar method to the RFE, which is also an elastography method in MRI, but that's still in the works.
And then there's also a study that is going to be finishing up in the next 2 years at the University of Florida that the NIH is also participating in, that is part of a Wellstone muscular dystrophy grant, and they are evaluating collagen 6 and Duchenne muscular dystrophy patients to determine the correlation, which is very important, between functional impairment and MRI changes. Because let's say, for example, the MRI does or doesn't change while the function does change, then the outcome measure using the MRI may be less relevant. Like, you know, if your MRI changes a whole lot, but functionally you stay the same, what good does that do for us in terms of assessing change? So this is also a very important study, and it's been wonderful to see the level of collaboration between the University of Florida and the NIH, who are assessing the MRIs in Lamina 2, collagen 6, and then at the University of Florida they're doing collagen 6 and Duchenne muscular dystrophy. So I think we're going to see a lot more of this. And the University of Florida,
we're going to compare our summer ultrasound data to the MRIs from Florida as well.
Yeah, it's fantastic. So there's really a lot of movement forward in terms of trying to understand how to use imaging, how does it correlate with function and functional change, and how much does the imaging change on an annual basis for better or for worse, and in response to therapy. So, you know, I think this is really an up-and-coming field. As Naz is saying, this potentially would be a fantastic solution to avoid, number one, the use of muscle biopsy to assess outcomes for many reasons. One is pain, but also because, remember, muscle biopsy is only a small section of that muscle, and how do you know that the muscle uniformly changes to a treatment?
Right, right.
So, you know, you may get a tiny little snippet, and that area may show no change, but the rest of the muscle may actually have improved in some way. So I think when you're assessing on imaging the entire muscle length, you have a much better picture of whether there are significant changes to that muscle. So it's all very exciting, and Naz is really leading the way in terms of raising awareness by neurologists for how to use the ultrasound for diagnosis. As you know, many patients with congenital muscle disorders remain undiagnosed. And you could see how in a quick clinic setting, if you could throw an ultrasound probe on somebody and make a diagnosis of RYR1 based upon the pattern of involvement or step in one, how incredibly useful this would be in terms of ordering the appropriate genetic testing and more focused genetic testing.
And I'll be honest with you, because I'm trained to do EMGs as well, and when I first started working at the NIH, I wasn't a believer in muscle ultrasound. I was like, oh, EMGs are the best, you know, blah, blah, blah. I can't begin to tell you how much more important ultrasound is than EMG for myopathic changes in children, for sure. And I think even so in adults, because you can actually see the distribution of a myopathic change. And also in kids, if you're doing an EMG in a kid, you basically have 1 or 2 shots to get at the muscle before they start going crazy and screaming. And in order to elicit myopathic changes, you have to have someone slowly activate your muscle. Good luck having a kid with a needle in their arm or their leg trying to do that for you. And then if they can't tolerate that procedure, then they actually sedate the kids for the EMGs, and the way you can actually get the kids to activate their muscles slowly so you can actually see if there's any myopathic changes is by tickling their feet as they're being taken out of sedation and trying to get a little semblance of something there. So it's a very limited study in children. It's something that's been historically used and I think could be really, really replaced by muscle ultrasound.
Yeah, I think it's very interesting to see the changing practice patterns for both muscle biopsy and EMG versus imaging over time. You know, as people get further and further away from doing muscle biopsies, a whole generation of neurologists will not be as familiar with the changes that one might identify. And it'll be very interesting to see how this field evolves.
Mm-hmm.
Naz, this is Charlene York. I have 3 generations of collagen 6 in our family, and it was my daughter who was diagnosed with it first. And I'm just very excited about the opportunity of having an ultrasound done first. She went through everything, the CAT scan, the MRI, the EMG, and then we finally got a diagnosis with the genetic testing. And I think if we had the ultrasound done first and then knowing what path to go down, I think that would have saved us a lot of trips to Children's Hospital.
That's right.
And you know, fortunately for her, she was 16 at the time when she was diagnosed, so there were no issues of being sedated for the MRI, and she kind of enjoyed the EMG being done, you know, that kind of stuff. And I'm also looking forward to when the genetic testing can be cheaper done, you know, because it's just so it was so expensive just for the insurance at the time. So, and just to let her, you know, that she's in the Florida study too. She's down in the Florida study. So, you know.
Yeah, I think the genetic testing is going to revolutionize the field because it's also because it's going to become a lot faster and a lot cheaper. And as more and more genes keep getting discovered, these chips that they have where they run the DNA on them are just going to get more and more sophisticated, and you're going to get quick answers.
Yeah, and at least with the ultrasound, it's so it's so easier than you know. And she even had a muscle biopsy done, but that was done after the genetic test, you know, confirmation.
Right, and even the muscle biopsy requires like specific staining that not all places do.
Right,
and wouldn't even know to look for.
Right, and you know, just the whole, we went through the whole gamut, and and that genetic testing was the last thing to be done, and they were just trying not to, because of the costs, you know, they were trying to whittle out or try to get a diagnosis through the MRI, through the CAT scan, through the EMG, and nothing was coming up. And so we finally had to do the genetic testing. So.
Yeah, I'm going to be honest. I was going to say, just to give you an idea, I did a formal neuromuscular fellowship before coming to the NIH, and I saw 1 case of collagen 6 myopathy. Never saw LAMA2, never saw alpha-dystroglycan.
Right.
So just to show you that, you know, I could have started working as a neuromuscular physician right after just that experience. And not having ever seen these patients. So how, you know, that's kind of why it takes so long for people to diagnose patients, is because they just haven't had the exposure.
Right.
So as much guidance as possible, and I think with non-invasive guidance as possible, it would be really helpful. So.
Well, Naz, I want to thank you so much for your fantastic presentation. It was really great, and it's always helpful to have it explained so clearly. I think this will be helpful for families and other clinicians to also access. And we're really looking forward to having you come back to talk to us about MRI. So thank you again for your willingness to carve out time to give us these wonderful presentations. And we will follow up, Stacy and myself, with you. And looking forward to seeing you soon.
For sure. My pleasure.
Sounds great. Talk to you.
Okay. Take care.
Thank you.
Okay, my pleasure.